Welcome to this webinar. Today's webinar actually is to share learnings from the Accelerating Innovation Program and future opportunities. As you know, actually, the Accelerating Innovation Program was implemented by Frontline AIDS and actually funded by the Earth and John AIDS Foundation. Frontline Aid implemented the program in partnership with Allied Medical Service in Uganda and Alliance India. So before actually I continue, I'd like to give a rundown of the webinar and actually then I'll provide an overview of the program, and there'll be a presentation from Alliance India and equally a presentation from Allied Medical Service on learning of the program. And that will follow by structured questions and interactive sessions and a closing remark from the Earth and John AIDS Foundation. And before I continue, actually, I'd like to introduce the panelists. And please, can you kindly put your microphone on when I actually introduce yourself? So I'll start by introducing Dr. Pasquin. Dr. Pasquin, can you kindly please put your microphone? And so Dr. Pasquin is Executive Director of Allied Medical Services based in Kampala, Uganda. And also Dr. Elizabeth Kihaki, who is the Head of Program Allied Medical Services. And in Alliance India, I'd like to introduce Tota Mahi Huari, or Mahi actually, as she's fondly called. And Mahi actually is the Senior Program Officer, Sexuality, Gender, and Rights in Alliance India. And then we have Dr. Roshana Mitra, actually, Director of Programs in Alliance India. And we have Dexter Patel, who is the Director and Founder of the Good Child Network of Positive People in West India. And finally, I would like to introduce Anne Scott, who is the Chief Development and Impact Officer of the Earth and John AIDS Foundation. I would also like to actually provide a brief overview and context of the Accelerating Innovation Program. And as we know, actually, this program was designed and implemented during COVID, and actually in the context where there was surmountable obstacles and challenges, especially from key population and marginalized population in accessing healthcare services. And so the aim of the project was essentially to test innovative model that perhaps could make HIV response resilient. And this model essentially were to mitigate the impact of future pandemic, including COVID, and also to ensure there was a continuity of HIV-related treatment, especially in surmountable obstacles or emergency situations, as a period actually dictates. And so before actually this project was implemented, you all know there was global pandemic. The COVID had brought in enormous challenges and obstacles in terms of access to HIV services. Countries all over the world had put in place lockdown. There were challenges in transport services, which makes it difficult for people to go to clinic and to the hospital to access HIV services. There were a lot of restrictions, and some of these were followed by actually arrest and detention of LGBT people on grounds of COVID restriction. And so that means that coupled with the COVID, that individuals, especially LGBT key population as a whole, and disadvantaged individuals have surmountable challenges in accessing treatment. And so the design was for us to look at test models, to test approaches, which makes it very, very possible or potentially can facilitate access to treatment under the circumstances. And so in some cases, as in India, the fear of COVID itself makes it impossible for people living with HIV to access treatment, just because they were not only stigmatized, but because they feared they could actually have contract COVID. And COVID, again, with the misconception, was thought to be somewhat devastating to the lives of people living with HIV. And so within that context, in the light of the lockdown, in the light of the challenges and the prevailing transport obstacles, the Accelerating Innovation Program was designed and implemented in Uganda and in India. And in Uganda, for instance, the main focus was on access to prevention, testing, and treatment services for people living with HIV, and also on self-care, especially for vulnerable people. And so the Alive Frontline Aid actually partnered with Alive Medical Services, and Alive as well partnered with community organizations in Uganda to implement two vital a piece of work within the program. There was an emphasis on the self-care intervention. Another emphasis was to ensure continuity of services from prevention, testing, and treatment. And so within that framework, Allied Medical Services actually did provide virtual and mobile platform, actually through which services through which key population and disadvantaged individuals were provided services, or would actually continue to obtain HIV services during COVID and lockdown. And equally, they actually did quite a lot on self-care. And that involves really trying to empower people to take ownership of their healthcare. And that involves actually HIV testing, training of health workers, empowering peer educators to actually be able to support HIV response during COVID. And so in Uganda, for instance, approximately 4,700 people were reached with different HIV testing and prevention services. There were a lot of virtual and mobile interventions through which services were provided in different platforms. There were partnerships with community organizations and government. And of course, as we listened further from the Allied Medical Service presentation, a lot of innovative models were piloted, they were tested, and were found to be effective, and for which we can actually use in future pandemic mitigation and preparedness. In India, actually, there was greater emphasis on strengthening communities-based system on COVID response. But as the program eventually evolved, that emerged or were adapted into vaccine uptake, and actually to address the economic and social impact of the pandemic, for instance, on mental health and economic empowerment. And so in partnership with the Alliance India and the Gujarat, a network of people living with HIV, Frontline Aid implemented an extensive, innovative programs in India. And this involves actually improving access to vaccines, to COVID services, and later on actually in vaccine uptake. And so there were a lot of interventions as Alliance India would present, but ultimately we see a lot of emphasis on the community ownership, on a partnership from Alliance India with community organization and the government to improve actually the well-being of a key population and those disadvantaged by or those who face surmountable barriers actually in accessing healthcare services within the community. And as Alliance represented, almost more than 10,000 people who actually benefited, and quite a lot of virtual and mobile intervention were provided, and there were also an income component of advocacy. And so looking at all the different strands of investigation and the heart of the implementation of this program, there were a lot of emphasis on community-driven system. And so the community actually in this sense actually play an important role, as we've seen in HIV response, in terms of actually adapting to changes, adapting to shock and resilience, and being able to plan and provide services in different contexts and with a lot of speed. that we expect. And at the heart of it, which is in terms of how this project ensure or perhaps facilitated future pandemic preparedness, there are a lot of lessons which we want to, which we can learn and which we presented, as well as a lot of innovative practices which came as a result, which can be used in future pandemic preparedness and response. For instance, the concept, the idea of HIV testing or self-testing, which was peer-led, alternative models actually to provide ARVs to people's home, mobile and virtual platform, as I said, and as well as nutritional support, mental health, and economic empowerment. So I would like to pass on the microphone to Dr. Pasquin, for instance, Dr. Pasquin, to take us through the presentation phase from Alliance India and Allied Medical Service. Thank you.
Thank you very much, Mr. Columbus, for taking us through the overview of the projects in the two countries. Without wasting time, I'll call upon Alliance India to make their presentation. And yes, you're welcome, Alliance India.
Thank you, Dr. Pasquin.
Rachna, if you could just bear with me, I'll pull up your presentation.
Sure.
And I'll get that on the screen for everyone. Just bear with me one moment.
Yeah, thanks, Lola. It's visible.
I'm just going to make sure we're back at the beginning, actually, because I think I've jumped too far forward. Sorry, everyone. I'm just going to scroll back.
No issue.
Okay. Let me know when you need me to go forward.
Yeah. Thank you, Lola, and good evening, good afternoon, everybody. This is Rochna from Alliance India. I work as Director Programs in the organization. I'll just give a little introduction about our work, and then, my colleague Maheshwari, who has been kind of leading the project, will speak a little more about the entire innovation project. And then, of course, we have our implementing partner and, the organization, Gujarat State Network of Positive People, who has actually done the real work on the ground. Daksha will be speaking as well. So just to kind of introduce the project, we named it as Parivartan, which is a Hindi word, which means, and it basically literally means change. So we wanted it to be named like this because it's an innovation during COVID experiences, and during how we kind of try to learn from the experience that Alliance India has on HIV projects to take those learnings into COVID. Next slide, please. Lola, next slide, please. Yeah. So before I get into the project details and project location, just to give you a little overview about Alliance India. Alliance India is a community-focused and community-centric organization which started working from 1999 in India. And it's basically works on, HIV, health, and sexual minorities, which includes transgenders, MSM, gay men, and people who inject drugs. And it's all our partners are CBOs and communities, and community is at the focus of all our work. And that's why, all our partners by and large are community-centric organizations, community-based organizations, or communities themselves. So this project started off during May 21, and it was for a little more than a 1-year period, July 22. It was in the state of Gujarat, and the project was implemented in 4 blocks in Surat district, which is one of the districts in Gujarat where the COVID pandemic was, one of the worst affected in the COVID pandemic. Next slide, please, Lola. Yeah, so basically, as I was speaking about it earlier, Parivartan means change, innovation. This was supported by Frontline AIDS through the Elton John AIDS Foundation and was implemented in Surat district of Gujarat. The aim was to provide support for key vulnerable population during COVID-19. As in many countries, India was hit by the deadly Delta wave during April to June 21. And the infrastructure had collapsed. The vaccine rollout was initially, when it got rolled out, was a little slow. And there were huge suffering, particularly for the key population. So the aim was to provide support for key vulnerable population. And the strategies has been basically virtual outreach services through digital platforms and IC material, which was shared to empower people with complete and accurate information on COVID-19, advocacy and sensitization for healthcare services, peer group meetings to strengthen social support system, and of course, innovative approaches to provide the psychosocial support to COVID affected. And as my colleague Maheshwari will take you through the rest of the presentation, I just want to end by saying that, all these learnings that we tried to put in this project was from our long-standing experience dealing with HIV positive people and the learnings from HIV HIV projects, which we tried to kind of bring into this grant. Thank you so much for your attention, and I hope you get to know more about the work that Alliance India did. And Maheshwari, over to you. Thank you so much. Thanks once again, Columbus, Dr. Pasquin, and Lola, and all colleagues who have joined us. Thank you.
Thank you, Dr. Rochana. We are still with Alliance India, sharing more about their innovation. Thank you.
Thanks, Rochana, for setting the ground. So as Rochana says, Alliance India had the experience of working with key population. And as you all understand, COVID has hit key population to a large extent, like compared to the general population, key population, because who were dependent, were stuck in the homes or had to, were lost their livelihoods. So these are the challenges that key populations had. So Parivartan project focused on key populations. Next slide, please. Yeah, so as I was telling, because when we started the project, the proposal was set up to provide the treatment or the treatment and the care support like it was done in any other HIV program. But as the COVID progressed and the health system innovations were happening, the vaccination came into picture, then we realized the program needs the key population where not been provided vaccines or we're not able to access vaccines. So all the program strategies evolved as the COVID was unfolding itself. So like one activity that we added on later was vaccinations, because when the COVID hit, when the proposal was prepared, there was no vaccine in the country. So when the vaccine came in, the key populations couldn't access because they didn't have a valid ID card or they didn't want to visit the public health facilities, the fear of exposure. So we project decided that we will organize the vaccination camps within the office. And the second thing that came out during the COVID is many of them were facing mental health issues because they were stuck in the family, they were stuck in the hostile environment, as because of the gender, sexuality, issues like that. So they needed some counseling, some support, or they lost some of the support systems. And the third challenge that we also realized as a program was going on are these people have lost their sources of livelihood or did not have access for their economic income because of COVID restriction. They were not able to take up petty jobs. Some of them were dependent on sex work. They couldn't do sex work with this COVID fear. So as these activities, as the COVID situation was unfolding, the program strategies were being developed. Next slide, Lola. So I will share each of the project innovation in detail in my next few slides. Next one. The first innovation that I want to share is the exclusive vaccination for camps for key populations. Like as Rochna said, GSMP, Daksha, we are always struggling. Key population is not able to access vaccine. They didn't have ID card. What do we do? How do we go about it? Then we said, let's do a RATT. We will have a vaccination camp within the network office. And so we went and the GSMP plus Daksha and the team from the field went and approached the Surat that, Surat Municipal Corporation, we need, the key population need vaccinations, but we cannot come to the facility because positive people has a fear of exposure and sex workers or MSM population do not have an ID card. How do we go about it? So Surat Municipal Corporation is a government body which understood the challenges the key population had. So they said, okay, we will organize a camps in your office. So they came and visited the office. They ensured that we had the minimum requirements to organize the vaccinations in their facility. So they provided the vaccine. The team from the public health, the government hospital came down to the office and provided vaccination to the key population groups. So some key population who couldn't access the registration because registration was mandatory to access government vaccines. So the organization, the GSMP Plus, supported them in the registration process. So by this, all the key populations who have got the free vaccinations from the government supply through the efforts of the GSMP Plus and the project team at the field level. So as I made quote, one of the person says, he had a fear to take vaccine. There were a lot of myths and misconceptions about vaccination because some of them thought that the virus may attack them if they take the thing, or their health may deteriorate, or there may be certain issues that come around the virus. And some of them were already positive with HIV. So they also had different myths and misconceptions. So as Dr. Bhautik says, he also had fear that he might die if he take a vaccine. But he decided that I will go and take the vaccine because I need to set example for my other co-peers who are down there in the community. Next slide, Lola.
Mahi, just before you continue, the interpreters have asked if you can just speak a little bit slower, please.
Yes, I'm sorry.
Thank you.
Second activity that the project has done very enthusiastically was supporting the income sources of the key population. As I mentioned in my earlier discussion, most of them have lost the source of income because some of them depended on sex work, some were doing very small petty business like a push cart, selling vegetables or doing some daily wage work. They lost all that during COVID because COVID had strict restrictions on mobility, travel, things like that. So what project did was we identified such, and some of them lost sole breadwinners in the family due to COVID, like there was a death in the family. So what the project thought, we need to provide them some trainings or some income sources. So they identified such families who have lost the livelihood or who have lost some person due to the death. We linked them with the vocational training institutes. And the vocational trainings they choose was the computer training and the beautician course, because these two are something that's very easy to learn and they're very much in demand in our country. So they can have income, an immediate income once they complete the course. Also to the course, because we had a very time-bound project, we linked these communities with the government institutes that are providing these trainings. Because even after the project, if they need to continue their training, they will get a free training from those institutes. So Dr. Ambedkar University is a university in our country that we linked about 30-40 people with that university who is providing them training in computers and beautician course. So this was something that we thought in a sustainable way because the project may go and may not continue, but key population needs this kind of support even beyond the project period. So like one of the person says, the person who is associated with Bharati Ambedkar University, they were also very happy to be associated with the positive network because they said we often do our work, but when we connect to the key populations, the persons who are vulnerable, they feel very satisfied working with us. Next slide, Lola. Yes, this is the mental health. As I told you, key populations, as we all know, already go through a lot of stress in their lives because of their gender identities, because of the challenges they face within the family, friends, peers, because of their preference of different sexual compared to the others. So during COVID time, these mental health issues got more severe, because when COVID, like if I'm a sex worker or if I'm an MSM, I had my own different support system whom I used to meet every day, share my issues. But COVID made me limited to the house. They were like, had to stay within the house. And as you all know, there's not much acceptance for a different sexualities or, the key population groups. So this gave them a lot of stress, and some of them lost their dear friends or families. So death, always leads to grief and depressions, things like that. So Alliance, when we were doing the outreach activities, we realized there was many people who had mental health issues. So what the project did, we linked up with the local public health that is providing the mental health services. So they trained our project team in screening, doing the basic screening in the community, so that any potential people who have mental health issues or needs mental health intervention can be referred to the public health systems. But then, as we all know, mental health as such in India has a lot of stigma. So there's not much acceptance for a mental health. If someone has cancer, they're very happy, but they're comfortable going to the public health facility. But if someone is suffering from a mental health, like an anxiety, depression, they don't want to go to a public health facility or take treatment, because they feel they'll be stigmatized, or they may be labeled as someone who is sick or who is unwell. So there was a lot of challenge on that. But so outreach had to work around those challenges. Again, as we say, the Parivartan project, there's one person like Alka from the community who says during the COVID time, she was very happy to be associated with the project because she accessed both the project facilities, the mental health support as well as the financial support, because she lost her husband to COVID. So she was going through both these challenges, like mental health. She was suffering a lot of anxiety, grief type of issues. Plus, she lost the only source of income in the family. So she was very happy, and that's what she says, that the project has supported her very well. Lola, next one. So here I end my presentation. I think Daksha is here in the group. So when we go to the question answers experience sharing session, she will be part of, I would want her to share her experiences and more on those. Okay. Thanks, Pascal. Thanks, Columbus.
Thank you very much. Thank you, Dr. Mitra and Mahi, for a wonderful presentation. We've had the adaptations and the innovations that Alliance India did to ensure that services reach the marginalized populations in the community. We shall now hear from Alive Medical Services, how they made the innovation. Dr. Liz will take us through the presentation from Alive Medical Services. Dr. Liz, you're welcome.
Yes, thank you, Dr. Pasquin. I hope my screen is visible. Hello, everyone. I'm speaking on behalf of Alive Medical Services. So this is just a build-up from what Mr. Columbus has shared concerning the accelerated innovation, this time implemented in Uganda. So okay. Sorry, yes. So in addition to what has already been shared, in Uganda, when COVID hit, Uganda experienced 2 lockdowns with school closures. We had suspension of public transport that later was eased to restriction, where we had half capacity being observed in terms for physical distancing, to ensure that people maintain physical distancing. But of course, that meant an increase in transport costs. And we had curfews that were imposed. So people who were moving from far had to make sure that they allow enough time to reach home on time. And of course, this affected the marginalized communities we serve, because most of them are the ones who are involved in the informal sector, be it in the bars, in the saloons, riding motorcycles, or running small kiosks and businesses, restaurants, small kiosks. So as a result, many lost their livelihoods and had to migrate to upcountry or rural areas. And that meant accessing healthcare was actually a struggle to a number of them. So Alive Medical Services, as a not-for-profit organization, as already introduced, located in Kampala, founded in 2007, operates a medical facility, which is also located within Namongo, Kampala, and we offer comprehensive HIV care, treatment, and support for all free of charge, and it's open 24 hours, 7 days a week. Our vision is actually a world in which all those in need of medical care have access to state-of-the-art medical services provided with love and dignity. And we strive to make sure that all our clients receive this. So in view of this, in implementing the accelerated innovation in Uganda, one of our key objectives was to ensure expanded access to prevention, testing, and treatment services for the people from the key populations, that is the LGBT, the sex workers, the people who inject drugs, people who use drugs. We have adolescent girls and young women. So all these were involved in this project. Then also we're looking at improving self-care for vulnerable people living with HIV. This way would build resilience to make sure that even if a similar pandemic comes about, these people have been empowered, are able to continue maintaining their health and maintaining quality of life. So among the many things we're going to share today, I want to share about 3 case studies of strategies we implemented. The first one being home delivery of ART and other commodities. Yes, when before COVID came in, people used to walk and move freely to come and pick their medication, do tests, be monitored, etc., etc. However, when the lockdowns came in, things got paralyzed, movement was paralyzed. Then even when the lockdown was eased, transport was still at a high cost, and yet many had lost their livelihoods and had kind of relocated to somewhere in far distances. And yet for clients who are on ART, many a times they don't actually need to keep coming. They need multi-refills and just to come in for monitoring tests once in a while. But also we recognize that our population, the marginalized population, because of stigma and discrimination, we're facing it hard to go and access some of these in neighboring facilities. So what we did was to see how we can actually make sure they continue receiving their care and treatment while comfortably without stigma and discrimination. So through this, we are targeting this men who have sex with men, LGBTI, orphan, sex workers, people who use drugs, all have access to their much needed treatment, irrespective of the different challenges they were facing. So ART, as well as commodities like condoms, lubricants, information, education, communication materials, were actually being sent out into the community to support both the care and treatment of people who are not able to access the facilities. People were contacted prior to find out whether they would be comfortable with which modality they would be most comfortable with to receive their care and treatment, if they're in position to come, or they would need to be supported in terms of transport. So what worked best? One, we had peer-to-peer delivery, where some peers would move into the community and deliver this ART in the homesteads of people. Then we also had those who preferred borders to deliver to them, especially those who are living within a radius of 50 kilometers from Alive Medical Services. So we'll package this very well and deliver to them, such that the people who are delivering were also actually not aware of what they were delivering, because they were well wrapped and the person receiving it was as though they are receiving a gift. Then initially, before public transport was eased, we had to use food trucks because food trucks were permitted to move to ferry food between districts from upcountry to the city center and back. But then later we also used courier services, and this proved to be services that could reach far distant areas, those who were over 200 kilometers from Kampala, where we are located. So through this, 1,257 beneficiaries actually received community multi-drug deliveries. And of this, we saw also around 276,000 condoms distributed, over 92,000 information and education communication materials were able to reach the people in the community because information was not penetrating well. Everyone was under a lockdown, but when we are able to use this system, we're able to reach them in their homes, in their communities. And then there are those who had to actually come to the facility, yet would find that transport they were not able to move because of the cost of transport. So these were supported with transport. There would be cost sharing. They would bring some and then we top up, and they're able to move and come and receive their care at a line. So overall, we saw an improvement in adherence and retention in care. Interestingly, we saw much better retention in care amongst the key populations and minority populations, marginalized populations during this period, vis-a-vis pre-COVID. And we realized that actually these services extended much further than we had anticipated. Then it also ensured privacy was maintained through special wrapping, as I mentioned. And because of the improved adherence and retention in care, we actually saw, as of the last, just concluded quarter, a 97.6% viral load suppression of all those who were involved in the home delivery packaging. So some of the key lessons we've seen: one, this home delivery is actually convenient and for especially stable clients as well as health workers. And I'm glad to note that at least in Uganda, it is now peaking and there's also being included in the differentiated service delivery models. It is cost effective. Some clients now who got wind of it actually request to instead contribute to having their medication delivered to them, as opposed to them coming, since there is no need for them to come as long as they're not due for the monitoring tests. Then updated contacts and addresses are vital. So we have continuously been updating our contacts because people keep changing addresses and their contact numbers. So for this to be effective, there is a need for continuous updating of contacts and addresses. And then we were able to extend the geographical reach of our services, in that even those who were in Kampala and had to relocate up country, they are still able to continue receiving the services. The next case study was really around peer-educated assisted HIV self-testing. Yes, when COVID came in and there was a lot of lockdown, when people were fearing to go to facilities in the fear of contracting COVID. So that means this drop walk-ins for HIV testing, there was a drop in walk-ins for HIV testing services. So, and most of course affected were also the marginalized populations. Yes, as per our guidelines, we are supposed to at least have them test at least once every 3 months. But then we noticed that this dropped, and this had an implication in terms of prevention. So what we did was really scale up the HIV self-testing, distribution of HIV self-testing kits through the peer-to-peer models. And we noted that as peer educators were distributing this HIV self-testing kit, it became a gateway for other services to be accessed. In that, one, it kind of was an opening for rapport within the community. When they would say, oh, there is a self-testing kit, would you be interested? They would embrace it very well. And then that would lead to further counseling, information, passing on of information. And then when the test comes out, is either when in fact it is reactive, then the person is linked to us so that we can initiate them on treatment, confirm the test, do a confirmatory test, and then if at all it's positive, we initiate them on ART. And then those who would have a negative test, the peer educators would go ahead and discuss with them, assess whether they're at substantial risk of getting HIV. And when this would be identified, then they would be linked once again to us so that they could be initiated on PrEP. And this actually worked out as a really successful two-way model of utilizing the HIV self-testing kits. Then, of course, also other prevention measures would be given. For example, condoms and lubricants would be distributed in the process. So through this, over 2,500 HIV self-testing kits were issued, and a total of 140 people actually had a reactive test kit that in the end were also enrolled onto ART care. Then through this approach, 134 beneficiaries were able to be identified, initiated, and are actually continuing with PrEP at Alive Medical Services. So it was really a great success in terms of promoting prevention, combination HIV prevention in the community. Lessons learned, yes, there was an increased uptake of HIV HIV testing services. It was indeed also a gateway for other services like ART, PrEP, condoms, and lubricants. So it was a useful measure. And we noticed even those who would resist to do an HIV test, they were keen at doing an HIV self-testing test, and then whatever result will come out will give them the boldness to either come and be initiated on PrEP or actually start ART in case they turn out to be HIV positive. And our final case study was really around virtual adherence counseling and information sharing. So once again, people were locked up in their houses, and yet for those who are on ART and having unsuppressed viral loads, they needed to, the guidelines were like, they needed to come at least on a monthly basis.
Dr. Liz, you need to speed up. Thank you.
Thank you. I'm about to finish. Thank you. So as a result, we had to engage the virtual counseling and testing. That way, we are able to reach them in their community and offer them this intensive adherence counseling sessions while in their homes. Then those who need to be tested are the ones who would be supported to either come for testing, or someone would reach them in their community to take off blood to monitor their viral loads and their CD4 counts. So through this, about 1,371 beneficiaries were reached with virtual and telephone counseling, adherence, gender-based violence, and mental health seeking behaviors. And what we found very interesting is that of all those who were initiated on virtual intensive adherence counseling because of unsuppressed viral loads, 70% actually resuppressed on virtual intensive adherence counseling. So that means it's something that we can use at all times, even for those who are very far. So lessons learned, it is convenient, cost effective for clients as well as for the facility. It works well when combined with home delivery of ART, the virtual counseling sessions. And then it also promotes adherence and retention in care. So just in a nutshell, these were among the other things that were done, but we just picked out those 3 case studies. As Mr. Columbus already hinted, that we were able to reach 4,715 unique beneficiaries through this accelerated innovation. Thank you very much. Over to you, Dr.
Thank you very much. Thank you, Dr. Liz, for a wonderful presentation. Thank you also the team from Alliance for a great presentation. We've all had the great innovations by Frontline AIDS, AMS and Alliance India to increase the resilience of HIV responses to COVID-19, and of course, also looking in the future so that if there are future pandemics, there's already a preparedness. So we are now going into in-depth discussions with the panelists. we're going to delve deeper and learn more from these learnings. And I'll now, of course, I'll request the panelists to be precise and short in answering questions in the interest of time. And I will welcome Mr. Columbus to take us and lead us through the discussion questions with the panelists. Thank you. Mr. Columbus, please.
Thank you very much, Dr. Pasquin. Thank you, AMS and Alliance India, for such a wonderful presentation. And of course, a reflection of the reality and what actually happened in these two countries. We've heard from the presentations, and there have been key emerging themes, which of course help us or the program to actually achieve the results and actually to innovate and mitigate in the midst of the challenges, the COVID pandemic. There's been a lot said about adaptation, mitigation, innovation, person-centered care, differentiated service delivery, tailored services, peer-to-peer model, community-based intervention. And looking at the presentation and from what we've heard, I think that's actually a reflection of the magnitude of work which was done in Uganda and in India. I just want to maybe direct my first question to Alliance India, just to explore what actually worked well, and were there specific things that worked well for key population groups and key beneficiaries? Thank you. And just before you come in, please, can I just say that we have some questions coming in from the Q&A, for which we are very grateful. Please continue to send in your questions. We'll do our best to respond to some of them, mindful of time, and equally use the chat for reflection as well. Thank you. So over to you, Mahi.
Yeah, thanks, Columbus. So what worked well, as I told you, we working with the government agencies and tying up with the public health system and the vocational trainings also with the government recognized agencies was really good, because that ensured the key population had continuity of the activities even beyond the project. And what were some of the challenges, as I told you, the taboo on mental health, the stigma that is around mental health. So we couldn't get as many people as we wanted, or as there was a need in the community, could not be addressed totally. And also, like, working with these government agencies means there was a lot of documentation, there was a lot of paperwork that had to be done. So that was a bit of challenge, but nevertheless we stayed through that.
Thank you very much. Thank you. Dr. Liz, in Uganda, for instance, I think there's quite a lot you've said about HIV self-testing, especially peer-led, and more especially by maybe LGBT peer educators. I think that's emerged as one of the very best and innovative practice, which can be replicated in the future. But were there other specific or very unique approaches which actually stand out in the context of HIV provision in emergency situation? Thank you.
Yes, thank you very much, Mr. Columbus. Of course, one thing we really appreciated is the need for flexibility and innovativeness. For example, when it came to making sure that they access the ART, we noticed that many would need it to be in the communities. But then there are some instances where they would need to be tested, but they are not able to move because of maybe the cars were restricted. So would either send a team to their homes to take off the blood samples for monitoring tests, or would have one of our motorbike riders who has laboratory skills going ahead to actually collect the samples from the community. So it really involved a lot of adjusting according to the need that was identified, but most importantly, listening to what the need was at that point in time. Thank you.
Indeed, thanks very much. Still, Dr. Liz, I think an important dimension of the project itself was the need for us to learn, to adapt, and to do things differently, maybe for future outbreaks or pandemic. So what was it that you could have done differently, or perhaps the program could or may do differently next time?
Yes, thank you very much. So, of course, at the beginning of using this accelerated innovation, for example, the home deliveries or full cost was being taken care by the project. But then as time went on, we started discussing with the different clients, and because they realized it is cheaper for them to use this mode of accessing their care than them coming, they realized they can participate in cost sharing in terms of having this worked out. So that was one thing that we saw really was working well, and for sustainability purposes, having that cost sharing coming into play was also important.
Thank you very much. And to Mahi or Alliance India, again, just, I mean, imagine actually you did quite a lot. There were a lot of creativity. There were a lot of different dimensions. We hear that as the project moved, actually evolved, especially in the light of COVID, there were changes, there were adaptation. And I was just wondering, what will you do better apparently in case we have, I mean, an emergency in the future?
I think what we have to do is, because as an organization, we had good support at the district level to implement the program that actually helped us in taking the program forward and do the innovations as much as we wanted to. And also I should say, thanks to the frontline aides and the donor, there was a lot of flexibility in using these funds. Or the project activities, because innovations were not possible if we didn't have approvals to revise the work plans or rework on the activities. So what if I had to do differently in an emergency situation is, I think we as an organization should be prepared and should have enough community linkages and things like that, not just in one district, but pan India as much as we could do. So that it's not just we took up Surat because we had an agency there. So as an Alliance India, as an organization, we try to strengthen our linkages and this type of ground level rapport and our visibility in the project, so that we can take up anything quickly and do it the need based. And then while putting up proposals, we should put up a lot of scope for innovations, especially if it's an emergency situation or not an foreseen things. So that will give us scope to work around the things. And the project duration, of course, will be a little longer than just 1 year or things like that.
Thank you. Just again, in case of future, I mean, emergency or pandemic, are there ever specific intervention which you could replicate in the future, especially looking at key population?
I think the thing that really worked is a mental health, because irrespective of emergency in India, I think that's one of the area among key population which is largely ignored or largely not a felt need among the communities. So we as an organization or any other project, I think we should work on that or build on that. And the second thing is also public health system, because when COVID came, it just threw up the challenges that the public health system had in addressing, because government decided we will roll out the online registration, but there were so many features in accessing those or having an ID card, things like that. So these are some of the challenges that might come up even in an emergency. So we have to do necessary advocacy with the public health systems or support those in any other way possible with an organization.
Indeed. Thank you. Dr. Lees, I was just wondering, what...
Columbus, before you go on to the other panelists, I just wanted to add what Maheshwari just said, that, during the COVID pandemic, particularly during the second wave, the public health structure had totally collapsed in India across the country. So, these small bits and pieces that we tried to do through the project really went a long way in helping the most vulnerable key population who otherwise were totally devoid of any services. Because, you understand, Columbus, in a system where the general population is not able to avail the services, the marginalized key populations, are more and more vulnerable and more marginalized. So these kind of projects, which did a little bit of innovation, tried to help them through the pandemic was really, I mean, I think it's a big step in dealing with future pandemics, and and also prepare the community for preparedness. So just wanted to add this. Thank you.
Indeed, I agree totally. Thank you very much. Just the last one, Dr. Lees. Again, in Uganda, actually, a lot was done, and within the context of COVID, and actually targeting marginalized groups and key population. I was just wondering, based on the learning actually of implementing this program, were there actually, is there something actually which stand out, which perhaps can be used or can be replicated in the future?
Yes, thank you very much, Mr. Columbus. Actually, a lot of these are replicable, and we're actually continuing with them. Case in point, the virtual intensive adherence counseling. We find that even now, yes, they have to still come once every month for at least 4 months to attend counseling sessions. But we noticed before that very few would actually come on a monthly basis. So they would fail to suppress because they were not able to make it on a monthly basis. They would receive refill for 1 month so that they could come back for another refill after 1 month. But with this virtual adherence counseling session, they're able to get a multi-month refill and followed up while in the community. And I think that is why we've seen, we've registered a high success rate in terms of resuppression of those who were unsuppressed prior to this. And it is low cost in that we don't need to do virtual in terms of internet, but also phone calls work very well for those who are for the clients. Then looking at the home delivery, the home delivery is also very replicable in that depending on where you are, the client does not necessarily always have to come to the facility. It was a change from the community drug delivery before, but this one making it more stigma-free, I would say, especially for the key population, because it is individualized. Then, of course, finally, looking at the use of the HIV self-testing. The HIV self-testing is something that is being expanded within Uganda. They have also included more populations to be to utilize this very service, and we're seeing that it's really bringing the remaining 5% we are pursuing to get to know their status while in the community. They are able to get to know their status without at an ease. Thank you.
Thank you very much, Dr. Lees. I would like to ask some very few questions from the chat, and hopefully with time permit, we can be able to ask all the questions we're actually receiving. But thank you so much for sending through your question. And then the very first one is from David, and this is is to Alliance India. It says, did you register unusual rates of sexual violence amongst KPs, either as victims or perpetrators in India before and after COVID lockdown? I've often read of high rates of SGBV in India, and I'm not sure how this relates to the key population in India. Thanks.
Yes, Columbus, there were high reporting of violence during the COVID time, because as I already told you, all of them were stuck in their homes in the hostile environments. But the women in sex work reported high violence. There were a lot of domestic violence cases or interpersonal violence that was reported. So the project, what we did, we had in some IEC tools to support the women in case they face violence. How do we do? So we widely use these IEC tools through virtual media, like we use them through the WhatsApp groups and through the Facebook or the public social media platforms. We share these IEC tools, and we share the helpline number that if any women or man is in distress or facing violence, what they should be doing about it, and necessary support from the public government systems was provided to these people.
Thank you. And let me just ask the next question. And this one from Kate. It says, and it's directed to Dr. Lees AMS. It says, how will you ensure those eligible and due for VL bleeding or A1 or IAC, sorry, receive the services in addition to drugs refilled when the use of the above with the use of the above delivery innovation. Again, how will you ensure those eligible and due for VL bleeding or IAC receive their services in addition to drug refilled with the use of the above delivery innovation?
Yes, thank you very much, Kate, for your question. So I believe you're talking about the home delivery of ART in the community. Yeah. So yes, when we would first assess the eligibility of the client for viral load, and then explore what avenues do we have in collecting the blood sample. So if at all the client is a far distance and their main challenge is probably transport to come, they would support with transport. But if they are within the vicinity, within a radius we can reach, would send a team and they're able to bleed them, collect their blood samples from the community. That way, we would, prior to even sending the parcel, would have already cross-checked what is their viral load status, when are they due for the next viral load, so that the refill is takes that into consideration. Thank you.
Thank you, Dr. Liz. Just before we go, there's one more for you. And again, it's from David. And it says, when you mentioned that the home-based approach is cost-effective, it is cost-effective on the side of the client, stroke KP, sorry, or the service providers or AMS. In effect, where do you place your cost-effectiveness? Is it within the KPs or with AMS?
It's actually both ways. It is both ways, and I'll expand on that. When it comes to being cost-effective for the KPs, in that one, they'll not have to get, in terms of money, transport moving from their home to come to the facility and back. That cost is kind of reduced. And then also the element of time is also put into consideration. Then when it comes to AMS, yes, AMS, for starters, when the clients come, of course, the number of the patients to be seen increases, so that means time also is utilized. Secondly, in one of the meetings, I remember when they were discussing the cost effectiveness, they were like, you see, okay, when the client still comes, they will need to flush the water, they will need to switch on the lights, they will need, a number of other indirect costs that are involved. And yet this is a patient who is stable and does not necessarily have to keep coming to the facility directly. So the cost effectiveness is two-way in this scenario. Thank you.
Thank you. That's very clear. And can I just say that for the attention of those attending, please, you can read more on the, actually we have the learning document actually, which capture all the learnings about this program. And it's very useful with some very good pictures, exciting pictures, so to speak. And it documents all of this intervention and the learning the best practices and opportunities for us to replicate in the future. So please find that on the links on the chat, or the scan, or you can actually scan the QR code at the end of the webinar. And you actually, if you need any more information about that, please don't hesitate to write to us or to contact us. And we can literally share that with you after this webinar. I think my time is almost up, if I'm not mistaken, Dr. Pasquin. And can we move on to the next session?
Yes, Mr. Columbus, thank you very much for taking us through this session. I would now request you to invite Anne Scott from EJAF to give the address. Thank you.
Thank you, Dr. Pasquin. And just before Anne comes in, just on behalf of Frontline Aid to actually thank the Elton John Aid Foundation for the wonderful partnership and the opportunity for us to carry out this important project. So thank you so much, and Anne, you're welcome.
Great. Well, thanks, Columbus. And I likewise wanted to just appreciate the teams from all of the presenting organizations. Your work is so bold and so brave, and you really just stepped in the face of uncertainty and crisis, and as a result saved many lives and upheld health for many, many people. So I just wanted to appreciate that to start with. I just have two overarching comments that I hope will maybe weave together a lot of the themes that have already been mentioned. So I'll be very brief. But I just want to stress and emphasize the power and importance of community innovation. It really is an engine of creativity for rapid response. Over and over again, we heard about the rapid piloting of models quickly. And those models, I would say that it's really in the DNA, so to speak, of all the models to make them cost effective and to make them designed to address stigma and to uphold confidentiality and ensure the respect of all people that are interacting with services. So that was there as a common thread throughout. But just that work of innovation where you're just rapidly piloting models, adopting the promising or proven ones really quickly, dropping those that don't work, and moving on to mobilize that rapid response. Some of the key themes for the rapid response that and for staying the course to contain or where possible eliminate pandemics that I think are really important. The first one that jumps out is caring at all levels. So that self-care, that peer-to-peer care, that caring and ownership of the community, that was just the bedrock of the whole success, I think, of the effort. And that power of community systems. And I think the really important point of linking those community systems to government systems, because governments can't do what communities can do, and communities can't do some of the things that government can do. And so really making sure to not work in just at the community level, but to really build that bridge to the government was really important. And I think the other thing was using technology to overcome that isolation and going to reaching people where they are. And I just, it struck me for all these points, the comment that we have to remember that the whole government public health system was actually shut down and people were stuck in their houses in many situations. So just it may not feel like that in all places today, but just how serious that was, and in India and Uganda and other places. But there was some downsides to technology where misinformation was maybe spreading or there were scams around vaccines. But on balance, I think the power of technology was used as part of that innovation. And finally, a holistic response that puts people at the center. And so thinking about holistic response to services, whether that's mental health services or for COVID or for HIV, and it opened up a gateway to other services, PrEP and others, but also looking importantly at basic services, housing, food, but also looking holistically at transport, livelihood, and mental health. And I think to continue to advocate for the importance of those holistic services in pandemic response is really, really important. So those were just some of the key themes I heard to try to tie it all together. And I just want to thank you all for your amazing bravery, boldness, creativity, and just the importance and the impact that made in so many people's lives. And on behalf of Eve, Jeff, we're just really proud and humbled to be able to support your great work.
Thanks. You.
Back to you, Dr. Pesky, and then Columbus.
Yes, Mr. Columbus, I think I'll hand it over to you.
Thank you, Dr. Pesky.
Thank you very much. Yeah, yes.
Thank you, and thank you so much for those comments. I just want to thank Alliance India for a great support, partnership, and the great effort they put into this, as well as Allied Medical Services. And to the team in Frontline Aid, thank you so much for putting all this through. And for those who actually are attending, we are very grateful for your support. And as indicated earlier on, there's a publication around this. The link is on the chat. Please feel free to scan the code or to download the link or to contact us, and we can always share that information or the document or the project with you. And so thank you so much, everyone. Speak soon. Bye-bye.